presentations today, I really just want to give a bird's eye approach, or bird's eye view of what this whole topic is about, and sort of what our model is at Riley and the IU School of Medicine. So I'm hoping to at least spur downstream questions and comments, or at least motivate people thinking about this, hopefully have them reach out to their respective providers. So I am a cardiovascular genetic counselor. I work with the IU School of Medicine in Riley. I have no financial conflicts of interest, but my work is supported by the IU Strategic Research Initiative grant. So these are kind of the main areas I want to cover today, but I really wanted to hit on the current knowledge of CHD genetics, as well as the genetic testing strategies we can use for patients and families, as well as emphasizing the familial implications, which is my particular interest and focus. And I also want to talk a little bit more about our cardiovascular genetics model. So we do have a multidisciplinary team involving geneticists, genetic counselors, cardiologists, and even specialists in adult CHD. So I think we've got a great team assembled to address this. So let's go ahead and get started. So this is actually information that should be common to most individuals in this room. The birth incidence, generally about 0.5% up to 1%. These are the number of new events that occur in a given time period. Really the vast majority of all CHDs are isolated, so they're non-syndromic. They're not associated with other congenital anomalies or birth defects. The flip side, of course, is that roughly about a quarter are associated with other congenital anomalies, and often those constitute well-known genetic syndromes that we often get involved with. And the next few points, really, the fact that the birth incidence really hasn't changed much over the last 5 decades, in addition to the fact that we often do see familial recurrence. Both of those together show us that there's actually probably genetic factors involved in every single heart defect we see. The big trick, though, is being able to actually identify what's going on, which is the billion-dollar question right now. So the last point is that a lot of sources are now saying that there are more adults living with CHDs than there are children, and this is really due to amazing advances in surgical and medical management care of these patients. In addition, as more people survive and thrive into adulthood and have families of their own, more and more questions are coming out about those individuals and their families, potential recurrence in their future children. So right now, it's a little frustrating. We only really can identify causes for heart defects. These are identifiable genetic or environmental causes, really in only about 1/3 of cases. So we're stuck in this big gray area. About 70 to 80% of all we really don't know. Long story short, we just have to get smarter. Of the known causes, they're particularly numerous. So environmental causes include maternal diabetes or infections during the pregnancy. And actually the genetic causes of heart defects are extremely numerous. So we know of chromosome disorders, chromosome syndromes, single gene mutations that cause particular genetic syndromes. But right now we're really trying to work hard, and researchers are working really hard at addressing this big gray area. And I think that what we're going to find is that we haven't gotten smart enough yet about this gray area, but I think what we're going to find is that it's going to be a complicated interaction of multiple genetic factors, multiple environmental factors, and even things that we call epigenetic factors, which is a little bit beyond the scope for today. In 2007, the American Academy of Pediatrics and the American Heart Association outlined 4 reasons why they thought that genetics involvement was extremely important for the CHD population. The first is that there may be other organ system involvement. So in many cases for genetic syndromes, the heart may be the only, or at least the first presenting feature for that particular disorder. So we actually try to get involved with every kiddo with a heart defect in our NICU and really have in-depth evaluations. And that ties into number 2, which is that the diagnosis for those particular disorders really provides good information to the healthcare team, provides good information about long-term or at least acute medical management, and it also provides good information about clinical outcomes and information for the parents and families. The last 2 points are a lot what I focus on, which is that there may be important information about recurrence, and many families have those questions and concerns even initially. And that also ties in with the last point, which is that there are actually relatives who we know actually may benefit from sort of downstream cardiac screening as well as genetic testing. So I sort of divide these 4 things up into 2 domains, which is involved in genetic evaluation, but also the genetic counseling. And so I can help a little bit with all 4 of these, but that's why our multidisciplinary approach sort of tackles these individually. This is by no means a comprehensive table. There are well over 200 known syndromes caused by mutations in single genes that are associated with heart defects. So what I would point out here is that the genes are on the left-hand column. In the middle column shows these particular syndromes, the name of them, and then on the last column, or at least the right side, I point out that there are potentially a whole array of heart defects per syndrome. So right now, we really don't even have a one-to-one correlation between a particular mutation and a particular gene that causes only one type of heart defect. So this will hint on something that I stress later, which is the variable expression of the genetics of heart defects. This table also does not include well-known chromosome disorders or chromosome syndromes like Down syndrome or trisomies 13 and 18. I can't stress enough about the importance of family and family history in the evaluation of our kiddos with CHDs and families. So one of the largest and most consistent risk factors across the board for CHDs is a positive family history. This table, sorry if it's a little small or a little fuzzy, but this table is taken from a common genetic counseling text that looks at heart defects across the whole spectrum. It doesn't look at individual types of heart defects. And what you can see in the top arrow is that the closer related to individuals are that have heart defects, the stronger the genetic basis is, or at least the stronger or higher the recurrence chances. So if you have one kiddo in a family, each of the other siblings potentially have a 2 to 3% increased risk of also having a heart defect themselves. When you start looking at second-degree relatives, so if you have an uncle or a grandparent who has a heart defect, that risk drops down to maybe 1 or 2%. So it makes sense. The more distant the relative is, we don't really see the stronger genetic associations. The last arrow, though, actually shows that when we have 2 affected children or 2 affected siblings in a family, or if we have a parent and a child who are both affected, that risk jumps up to 10%. And when we start seeing more than 2 people affected in a small nuclear family, we see that risk jump up to 50%. So this was helpful information for talking with families who were concerned or had questions about recurrence, but this was actually very broad data. We really want to get more specific information. So Dr. Stephanie Ware is our program leader as well as a mentor, and she's actually published and has broken out this data into individual lesions, individual types of heart defects. But what is particularly fascinating about this particular table is that not only can we get information about whether the mother or the father is affected, but also whether there are 2 siblings affected. So in the third column, if we have one kiddo, one child in a family who's affected, generally the recurrence in that family is going to be anywhere between 1 and 5%. We start seeing 2 siblings, that can jump up as high as 10%. And I think what I would really point out here, and this is for even reasons I don't quite understand, but we still have to figure out, is that when we have a mother who's affected, the recurrence risk is even higher. And that's something I also bring up with even some of my pediatric female patients, that as they get older and consider having children, that risk is actually higher for them. We're still trying to figure out why this is, but this is actually the epidemiologic data, and we're still trying to formulate why we're seeing this data. This is the pattern that we are seeing. One particular area that's a personal interest of mine, but also a professional interest of our program, is the hypoplastic population. So we actually see that hypoplastic left heart syndrome is actually one of the more heritable heart defects. It has actually the strongest genetic factors that we know about right now. And we see a recurrence of roughly 20% or so if a mother or father is affected. And if you look over in the third column in that same row, if you have one kiddo with hypoplastic left heart, generally the recurrence is about 8%. But based on this data, what we've actually found is that not only is there a recurrence risk for hypoplastic left heart in future kiddos, we actually see there's up to a 22% risk for any heart defect in children. So that's showing us that we're finding much stronger genetic factors associated with certain types of lesions, but we're still trying to unwind this. It's a very complicated story. I won't go over the details of this. It's very small and kind of fuzzy, but what I like to show in at least the second to last column from the right is something called the relative risk. And that basically tells us what is the likelihood of an event occurring based on a certain situation. In the top example, we look at heterotaxy. If we know in a small nuclear family there's one person with heterotaxy, all of the closest relatives to that person are 80 times more likely to have heterotaxy themselves. The presentation's over. All right.
There we go.
Turns out I use genetics, but I don't use my hand very well. Yes. All right, let's head back. Okay, so we actually see there's a higher relative risk. There's higher odds of things happening based on family history. We also see this with AV canal defects and even right-sided heart defects. In some cases, these, in the case of AV canal, we see roughly 24 times more likely that a first-degree relative will be affected if there's somebody in the family. So all of this is basically a long way of saying that most CHDs probably have a genetic basis. Now, really, the trick is going to come down to, well, what can we do to figure out what those factors are? So we're going to change directions here. Now, looking at the genetic causes of CHDs, I've highlighted here, really the minority are actually caused by mutations in single genes. This actually quotes 3 to 5%, but we actually think it's probably a little bit lower, maybe 1 to 5%. The next two things highlighted are chromosomal and copy number variants. They're basically both chromosomal changes, chromosomal abnormalities we see, but the first one, chromosome/aneuploidy, is really looking at large chromosome changes, whereas copy number variants are very micro, very small chromosome changes that we've only really been able to identify in the last maybe 8 to 10 years. Either way, though, we're finding that more cases are attributed to chromosomal changes. In the case of some of the copy number variants, we're even finding them in isolated heart defects. These are non-syndromic heart defects. However, we start seeing a heart defect in the context of a constellation of features, particular for a syndrome, our chances of finding the answer, finding the cause, jumps up to roughly 25%. So it's pretty good, but still not the whole story, of course, and we're working on that. For any conversation I have about genetic testing, I make sure we're all on the same page, and that's that when we're looking at chromosomes are essentially the packages that hold our DNA. So it's just a single DNA molecule wound up really tightly on the structure of one chromosome. So when we do testing, we can analyze those chromosomes. We can look at their number, their structure, we can look at very small changes in them, because the underlying DNA is going to be altered. We alter the actual chromosome. To do molecular genetic testing, then we actually have to unwind a chromosome, look at the particular DNA sequence of letters for a particular gene, and try to find any variants or mutations in that gene that would cause, or at least be predisposed or be associated with congenital heart defects. There are two main genetic testing strategies really that we employ that's really across the board too, I think, and that's we look at chromosomal or cytogenetic testing, which is exactly what we're doing. We're looking at the structure and number of chromosomes. And again, we think we can find causes for upwards of 10% of isolated heart defects. We certainly about double that with syndromic heart defects. The next big area is the molecular genetic testing. That's actually where we're sequencing individual genes sitting on the chromosomes. So we're actually reading the DNA sequence and we're looking for mutations or variants in that gene that cause some kind of a developmental difference in how the heart develops. But we're really finding that seems to be a minority of cases right now. We're only finding it, again, about 1 to 5% of cases overall. So this was the gold standard of chromosome analysis. It's really been done for the last 40 or 50 years where we literally look under a microscope and look at the chromosomes. And it was really good at just telling us how many chromosomes were there and were there any large changes. In this example, we have chromosome number 18 down at the bottom right, where there's 3 copies of. This kiddo had trisomy 18 in particular. So again, this was used for over 5 decades, but really in the last 10 years, there's been clinical availability of really amazing tools. This is called Chromosome Microarray technology. And rather than looking under a microscope, we're actually digitally looking at chromosome material. So there were all kinds of chromosome changes we were missing for decades, but this tool is basically allowing us to zoom in on individual chromosomes and actually see very small differences that we missed years ago. In this case, we're actually zoomed in on chromosome 15 and we see a loss of all these probes, all these markers, and that's telling us there's a very small, what we call submicroscopic deletion on chromosome 15. As a result, that patient is missing copies of genes in that patient. So we can identify that now. It was something we could never do it prior to maybe 10 to 12 years ago. This is another image. This is actually chromosome 22 at the left, where we've seen a very small submicroscopic deletion in a patient with 22q11.2 deletion syndrome. And again, this is stuff that we can find out in the NICU setting, which is going to help us take care of that patient, as well as provide information about the family. A colleague and I recently published this review looking at these what we call submicroscopic chromosome deletions and duplications in isolated heart defects. I'm not going to belabor all the details here, but what we're finding is there's these sort of recurring chromosome deletions and duplications across the genome, across the chromosomes, and they're involving some common genes that are basically highlighting to us that these genes are involved with heart development. So it's helping us get diagnoses, but it's also helping us answer some research questions, or at least ask more questions, which is, what is this gene doing when we're missing a copy of it as a result of deletion? Or what happens when you have an extra copy of it as a result of duplication? And how can we use this information downstream to help make predictions about the heart? Now, shifting gears to molecular genetic testing, again, this is where we sequence individual genes. Really, the molecular genetic testing seems to be most useful right now when we have positive or striking family histories. So if we're seeing 2, 3, 4 generations with a clustering of heart defects, if chromosome testing is normal, we might actually start focusing on sequencing some of these genes and figuring this out. But the second point here really highlights that this is still pretty limited right now because we're getting really good at detecting mutations or variants in genes. But some of these genes and some of these variants are associated with a whole array of different types of heart defects. So again, it goes back to we don't have this one-to-one correlation quite yet where we can make a prediction based on a single gene. So that's where the next kind of area that we need to work on is. And that highlights the third point, which is this variable expression. You can have a mutation, a hit in one of these genes that causes the heart developmental recipe to go different, but we still can't provide predictions on what trajectory that actually takes, whether it's a VSD, an ASD, or tetralogy. And that's a really important point, is variable expression. The image at the right I stole without permission from a textbook that I have on heart development with genetics. There should be a citation there. Make sure you get that. But this is actually showing an interactive gene network. These are all genes known to be associated with heart development. And you can see it's really complicated. The heart is complicated. Developmental program the heart is a part of is complicated. And I think that what we're going to be doing, and the researchers are already there, the clinicians are getting there, is that we can't be taking, or we can't still have this very simplistic one gene view of everything. I think that's one thing to stress to people in the general population, that what we're likely going to see is that heart defects are probably a combination of multiple little variants across several of these genes that interact in a way that we're just not smart enough right now to understand, but we're working on it. The other thing too, and somebody mentioned this in the panel this morning, was that there probably are some variants in some of these genes that may sort of ameliorate the effects of a negative mutation or variant in a gene, maybe being a protective factor of heart defects. So this is a complicated process that we're still in the process of unraveling. Again, not to belabor the details here, but this was a table I threw together of some very common genes associated with isolated non-syndromic heart defects. And I've highlighted kind of three main culprits that we deal with. With the fourth is kind of a different story down at the bottom. But you can see again that NKX2-5 is a gene that we're really interested in. It's a gene that sort of helps program the rest of heart development. And we can see that we can find mutations in that gene, and it's great because we can make predictions about, usually we see septal defects with those kinds of mutations, but then you have a whole host of other things that's associated with them. And so it provides us a little bit of a crystal ball, but it's still foggy moving forward. And what we're actually finding is that, again, we're really only finding mutations in these genes in isolated heart defects maybe about 1 to 5% of the time. It's not to say how much we don't know, it just is more about how much we need to get patients and families involved in research to better understand this stuff. A recent study, though, looked at just these 4 genes highlighted red and said, well, they actually found causes for isolated heart defects in about 10% of cases. My own review of that study was, I think they have some limitations. I think it's a little bit of an overstatement, but I think it's still good information that we still need to work on. So we really have limitations in the genetic sequencing at this point. And what we're going to do is probably transition away from looking at single genes or even subsets of genes, and we're going to be doing things like whole exome, whole genome sequencing. Beyond the scope of today, but very fancy, very cool stuff that we're doing right now. And we also have, there are countless research studies going on looking at the molecular genetics of CHDs, but our own program also is recruiting patients and families to try to understand this stuff better. So, sorry for the terrible handwriting, I didn't have a chance to computerize this yet, but this is a typical family history that I often take. And you can kind of see that this raises more flags for me for one of these particular gene mutations, or potentially a chromosomal difference. But we see sort of a clustering of similar heart defects in the family. If we go far enough back, you can see maybe a great aunt who had 2 infants who unfortunately passed away, and they could have had heart defects just prior to the advent of mainstream or contemporary surgical techniques. So again, we would kind of focus on this, and I think that what I can highlight here is that we see clustering. It's not. So some people say, well, why aren't some people developing heart defects? Was this skipping generations? Which is kind of what I'm showing here. And that's often a misnomer or misconception. Our genes really don't skip generations. We inherit certain subsets of genetic variants, but it goes back to variable expression. We see this clustering. We don't know why some person develops one particular heart defect and one person never develops anything, but it seems to be that the expression of those genes in that particular person is different from everybody else. And this is really the family I have, that we see sort of a clustering of these left-sided heart defects. But this also tells us, I think, that we're a little bit biased in the fact that we see dad here in the middle, who's apparently totally fine, has had a normal echo, we assume, but then when we start actually looking or getting echocardiograms on family members, it turns out they've actually had mild heart defects the whole time that no one caught before, or undiagnosed. So I'll kind of hit on this a little bit later, but I think the data is a little biased because we weren't doing these large multi-generational echocardiograms on family members. I think we've been missing a lot, actually. This is sort of an algorithmic approach that we take with our patients with CHDs, and we start with this from left to right. We start with a particular lesion. We think of different causes, including whether it is a genetic or sporadic cause versus environmental cause. We think of syndromic versus non-syndromic things going on. But I want to highlight here that the background of this entire algorithm is the family history. That drives everything we do about downstream testing and downstream genetic counseling we can provide. And once we, of course, get involved and take all this into account with our evaluation, that allows us to talk about relevant genetic testing, allows us to discuss recurrence in families potentially, allows us to actually institute family screening programs in multiple individuals in the family. And of course, as the cardiovascular genetic counselors, we can also provide psychosocial support and counseling to families in whatever setting. So it's kind of the approach in general we take. So I'm going to shift again, because I want to make sure that we're getting through this for sake that we can have discussion or questions, but our team is multidisciplinary. And I think that there is a tremendous value, as people on the panel before had mentioned this morning, of people working together from disparate communities at least. And so I think of it in really a couple different domains, but the first is that there's a patient-centered focus on clinical management. So that's really where the cardiologists and surgeons get involved with caring for patients with heart defects. We have medical geneticists who can provide syndromic evaluations. And then we also have a family focus. So I often say that my patient is the patient, but my patient also is the family in many cases. So we can provide further genetic counseling, talk about clinical genetic testing, and then our program really tries to get these quote-unquote unaffected family members in. And we're actually finding many of them, I should say many, some of them are actually having or have very mild heart defects that they didn't know about before, and that's going to determine their future medical management too. So when we get involved, we say, okay, we have a kiddo in our NICU or CICU with a heart defect. Is it isolated? If it's not, if we're seeing other organ malformations, if we're seeing developmental delay, autism, we got our clinical geneticists involved. We're making sure they're doing evaluations to try to figure out if they can diagnose a particular syndrome, order the relevant genetic testing to do that. If the heart defect is truly isolated, we really feel it's isolated, then usually our cardiovascular genetic counselors meet with the family and we initiate testing. And typically our first line test is going to be that Chromosome Microarray, a very fancy chromosome test that's actually giving us a high yield for discovering causes. We also discuss the family history, we discuss recurrence and family screening recommendations, and of course we do follow up these families. I think that's important that, and again in the morning, that with our CHD populations, we really want to follow them across the age spectrum, and that's what we want to do too. Going to the family screening recommendations, there are some heart defects, and we kind of touched on this with the hypoplastic left heart syndrome. There are some heart defects that are actually extremely heritable, at least from our standpoint. So these include the left-sided heart defect, the left ventricular outflow tract obstructive heart defect. There's a list of them here under the triangle, and actually for every one of these cases, we are recommending and trying to facilitate echocardiograms in all the closest relatives. So we're looking at siblings, we're looking at parents, and if we're seeing adult patients, we're looking at their children too. And this is really important because there's been several studies that have come up with the same conclusion that when we have left-sided heart defects, 20 to 30% of the time, there's more than one person in the family with a heart defect. Often they didn't know they had it before. So we're identifying coarcs, we're identifying bicuspid aortic valves. And a recent study, this is really fascinating, this is a study that looked at infants with hypoplastic left heart, and they looked at all of the first degree, all the closest relatives of that infant. So they looked at all the siblings and all the parents. And they found that 11% of those people actually had heart defects, and they often didn't know they had them. So we found bicuspid aortic valves. So what was a surprise to me with this study, in the second row there, we actually found some people who had dilated ascending aortas, which we really want to monitor over time for possible risk of dissections or ruptures. And Josh made a good comment in the morning session, which was on bicuspid aortic valve. It is typically asymptomatic and usually not problematic until later in life, but we want to make sure that people know they have them because they want to be watched over time. Again, especially for that aortic enlargement. So these studies are highlighting the importance of genetic involvement, but also the importance of really getting family screening. So I kind of sum up my job really in a lot of ways as answering these questions. And these are questions that come from families. I mean, these are the really top 3 most common questions that I get in an NICU setting. I've got 21-year-old high school sweethearts who had their first kiddo who has dextrotransposition, and they're absolutely freaked out. They want to know how this happened, why did it happen? They want to know, is it familial? Are their future kiddos going to be at risk for this kind of thing? So I really try to hit on every one of these questions, not only in the ICU setting, within certain degrees and limitations, but even as we follow up these families, we want to be sure that we're getting this information to families and we're answering the questions that they have. And thinking sort of linearly, again, our program will really focus on evaluation and diagnosis, of course talk about recurrence, and then really our biggest focus is on family screening. So can we somehow identify people who did not know they had a heart defect or that was previously unidentified, and can we make sure they're getting the care they need? Because the earliest we identify these individuals, potentially we can prevent any dangerous things down the road, as our hope anyways. I just want to leave with this little blurb, and this came from a recent study that looked at individual genetic counseling sessions, individualized genetic counseling sessions for parents of kiddos with heart defects. And they found that overwhelmingly, roughly 96% found it to be positive, and many of them had questions that weren't being answered before. They really felt like genetic counseling should be sort of an integral best care practice for families of heart defects, and that's at least what we are trying to model and encompass with our program too. I'm just curious, raise your hand if you've ever sat down with a genetic counselor or at least had a very in-depth conversation about either your child's heart defect. That's great. That's wonderful. Okay. And was this? I'm just curious. Was this in a prenatal setting? Yeah. So prenatal genetic counselors tend to be very good about this, and we actually work very closely with our prenatal colleagues because we want to make sure that we're sort of across the pregnancy spectrum, if you will, that we're having these conversations before and after and making relevant recommendations for family screening. And heart defects are relatively common enough, it's going to take a very team approach to address this. There's not enough cardiovascular genetic counselors across the country to do this. So some conclusions I wanted to leave with. So I just wanted to stress the importance of genetics involvement for diagnosis, to review recurrence, to talk about family screening recommendations, identify at-risk relatives. The current cytogenetic and molecular genetic testing has a lot of great utility, but we still have a lot of limitations. And that's because really the genetics of heart defects is still quite complex, but we're still letting the story unfold and still trying to figure it out. Family history cannot be underscored enough. It's extremely important. That drives everything we do and what we can tell a family. And family screening is extremely important, especially for the heritable heart defects. And I think one last point I don't have here is that we really need people to push us to discover and identify the genetic factors for this stuff. So if people can actually get involved and ask those questions, saying, how can we get involved with research? What can we do? We need the parents and the families and the patients to actually push us to learn. So whether it's our program or somebody else, we really want to get people involved with research. We want to try to understand this better. Our website is currently under construction, but I do have my information over here, and I will have some business cards up here. So if anybody wants my contact information, they're welcome to reach out by phone, email, whatever. So that's all I have today. So hopefully we have time for questions.